Hello, I'm Dr. Donald Jurivich. I'm a professor of geriatrics at the University of North Dakota. This presentation is sponsored by HRSA as part of the Geriatric Workforce Enhancement Program. You can see the website here that you can access that for this presentation and for additional presentations on geriatric education. This presentation focuses on delirium, and our goals are to recognize two different forms of delirium. We want to also prevent delirium and manage it. So here's a case report. You have an 81-year-old lady who is having rehab in a skilled nursing facility, post-hip fracture. She usually has a good appetite, but declines to go to the dining room for breakfast. She looks tired and asks the CNA to put her back into bed and to close the window shades so the spiders don't get in. The CNA asks if there's anything else she can do, and the resident asks for a can of insect spray. So thinking about this case, what do you think is the most likely diagnosis? Do you think she has hyperactive delirium, hypoactive delirium, or a mixture of hyper and hypoactive delirium? Or does she have delusional depression? Or does she have dementia? So as you select your answer here, let me point out that the most correct answer would be hypoactive delirium. The patient presents as being tired, wants to crawl back into bed, wants to be left alone. The question of the hallucinations about spiders is a borderline criterion for hyperactive delirium, so it's possible that over time she might manifest a mixed picture. So to accommodate the 81-year-old nursing home resident, the CNA goes with the flow, and she brings a can of air freshener to deal with the bugs. The resident looks at her and asks, "Who on earth said anything about bugs?" The resident appears lucid and wonders why breakfast is so late. So now we want to think about what's going on here a few minutes later. And so does this change in the mental status indicate a waxing and waning of delirium? Is it the resolution or the end of the delirium? Or is it evidence that the delirium never existed? And then finally, what about the medication starting to work? So your best answer would be A, which is the waxing and waning of delirium. It's like a roller coaster. It goes up and down with periods of seemingly normalness, with other periods of inattentiveness and lack of awareness in the environment. So delirium is considered a disorder of attention and awareness. It's often referred to as the acute confusional state or altered mental status. There are numerous terms that are used. The delirium incidence is quite high. In the hospital setting, up to a third of the patients have delirium. Half of those presenting with delirium because of their acute illness, and the other half acquiring delirium within the hospital. Within the nursing home setting, 15% of older adults who are admitted to the skilled nursing facility have some evidence of delirium. So the prevalence is quite high. So delirium can be thought of as either a time-limited, it comes and goes, or it can be chronic and persistent. For ongoing chronic or subacute delirium, the risk factors include advanced age, underlying dementia, multiple chronic conditions, functional impairments, and sensory impairments. Also, an important point is that there's an increased risk of death, with the odds ratio being twofold greater, and the risk for dementia, if it was not recognized prior, is an incredible odds ratio of 12.5. So there's some quick assessments. When I'm in the hospital setting, I like to firstly just have the patient count backwards, usually from 100, but it could be 20. And you'll find that after about 4 or 5 digits, they start to lose track of what they're counting. For a more highly educated patient, you might ask them to subtract serial 2s or 3s. Subtract 2 from 100 and keep going. The other and more standard way to assess delirium is to use the confusion assessment method, or the shorter version of that, which is called the 3D CAM. The confusion assessment method basically has this set of criterion. It has to have an acute onset, a fluctuating course, inattentiveness, and then either disorganized thinking or an altered level of consciousness. So that leads to either the listlessness and hypoactive element, or the agitation and the fired up version of delirium. So it turns out that hypoactive delirium is the most frequent cause of acute confusional states, and it goes often unrecognized because it's just this patient sitting or lying in bed doing not much of anything. Almost a nurse's delight in some respects. So the important point is that you have to exclude depression. You want to ask if there's any new issues with shortness of breath, particularly if they have COPD. They might be a CO2 retainer, or if they have pneumonia, they might be retaining CO2 and have basically CO2, narcolepsy. Sleepiness due to high levels of CO2 retention. And then also you need to think about, was there a medication change that caused the low activity, or was it maybe a medication error? Maybe they got somebody else's pain medication, for example. In terms of hyperactive delirium, generally with the behavior you want to go with the flow. If they're having delusions or hallucinations, acknowledge them, and again, just go with the flow. You want to try to redirect their thinking somewhat, and ask them other things such as, are you hungry? Would you like a cookie or a snack, some water? And then also just think of environmental considerations such as dimming bright lights, trying to find ways to reduce the noise. And then also be mindful of your own facial expressions, and we'll talk about that in a little bit. And then really physical contact is a precipitant for a lot of agitation, particularly in dementia patients. So it's just cautiously approach patients with don't grab them, basically. So this brings us to this whole question of delirium versus agitation associated with dementia. How do you know what the difference is? Well, basically, if you understand the patient's baseline, that can really help inform. If they have periods of agitation or aggressiveness in face of dementia, then that's likely not delirium. But again, you can establish this by asking caregivers or family members about that. Delirium that might be superimposed on dementia would be indicated if it was a sudden onset and change in behavior, if it comes and goes as a fluctuating course, or if there's a change in consciousness, either on either end of the spectrum, listlessness, tiredness versus hyperactive state. So ultimately, we want to find the cause and treat the underlying cause that's causing the confusion. The British Geriatric Society suggests that acetaminophen or Tylenol be given as a empiric dose, basically 1,000 milligrams, to particularly in demented patients to treat delirium. And that's because the thought is that the demented patient cannot express pain. But still, it's important to try to identify pain or discomfort, whether that be soiled clothing or pain on touch, and you look for grimacing with joint motion. Also be sure that there's no alcohol or medication withdrawal. Don't assume that people in long-term care aren't drinking alcohol, as an example. And also be mindful of missed doses of medications such as tricyclic antidepressants and others that can cause withdrawal symptoms very similar to alcohol withdrawal. Also be certain to check the pulse oximeter, check the glucometer, make sure there's no hypoglycemia. And then in the COPD or chronic lung disease patients, consider CO2 retention, particularly if somebody had just bumped up the oxygen because of shortness of breath or dyspnea. Also, it would be prudent to collect urine for analyses and to get orders for blood tests. And then ultimately, you have to think COVID-19 or flu, even in the absence of symptoms such as fever and cough. They may older adults may just present with abdominal discomfort as the presenting sign of COVID, for example. So testing for these viruses may be part of the investigation into why the older adult has confusion. Okay, so some absolute don'ts, the no-nos. Don't tie people down. Strong evidence that shows that when restraints are used, bad things happen. And most long-term care facilities are restraint-free. So I just want to caution that it's a liability to use restraints. We need to talk about non-pharmacologic behavioral interventions, and you can see here these pictures on the right where you have a neutral face, and with a mask it still looks neutral. But if somebody's angry, or if you're responding in an angered fashion to the older adult's behavior, you're going to see furrowed eyebrows, wrinkles in the skin, forehead, all indicating an expression, nonverbal expression of anger or agitation or disappointment for that matter. So you want to try to evoke a calm facial expression. Try to use a reassuring voice. Mentioned earlier, try to go with the flow. If they're imagining something, acknowledge it. Don't countermand them. Just say, we'll check into it later. Again, physical contact can be a trigger, so be careful not to grab an older adult. And then address their comfort and safety, as well as issues about the environment, such as proper room lighting. Make sure that they have eyewear and that their eyewear is clean. A lot of times you find smudges on their eyewear. And then also utilizing hearing aids if they're agreeable. So to summarize, it's important to be vigilant for acute changes in behavior. If there's a loss of attention span, that's really the major finding with delirium. And they may lose a sense of awareness about their environment and safety. If they are psychomotor slowing, if they have slower speech, slower activity, that suggests hypoactive delirium. If they express delusions or hallucinations, imagined things that aren't there, that suggests a hyperactive or a mixed delirium picture. And really don't be fooled by the roller coaster ups and downs of delirium, because they may look wild and crazy 1 minute, and then a couple minutes later or hours later, they look totally normal. That's still ongoing delirium until proven otherwise, and it may take 24 to 48 hours to assess whether they have had their confusional state resolved. In the process of somebody that's in an acute confusional state or delirium, make sure you check the vitals, including temperature. And I want to point out that low temperature, hypothermia, is as bad as hyper or febrile temperatures. Also check the pulse ox and the sugar levels to make sure that those aren't causes of acute confusion. And then in the process of the workup, you want to make sure that the individual is safe, that they're comfortable, and again, the empiric treatment of unexpressed pain that's empirically treated with Tylenol, if not contraindicated in those that are cognitively impaired. So thank you for your attention. I hope you become a better evaluator of delirium as well as creating an action plan to reduce both its incidence and its sequelae. Thank you.